students. Today in this lecture we will discuss about trauma of the brain, trauma of skull, and head injuries by physical forces may result in skull fractures, parenchymal injuries, vascular injuries. All three can coexist. Trauma may produce closed or open head injuries. Injuries may be penetrating or blunt. The consequences of CNS trauma depend on anatomic location of the lesion, limited capacity of the brain for functional repair, injury of several cubic centimeter of brain parenchyma may be clinically silent if take a frontal lobe, and severely disabling in the spinal cord, and can be fatal in the brainstem. Skull fractures. The incidence of fractures is related to the pattern of falls, falling while awake. The site of impact is often in the occipital portion. Following loss of consciousness results in a frontal impact. 4 types of fractures. They are: first one, linear fracture, the most common. Next one, depressed fractures, and diastatic process such as and basilar. Typically follows impact to occiput or sides of the head, lower cranial nerves or cervicomedullary region. Symptoms are orbital or mastoid hematomas, craniospinal fluid discharge, the rhinorrhea and otorrhea, and meningitis. In this slide you see linear fracture and depressed or displaced fracture. Parenchymal injuries, concussion, mild traumatic brain injury commonly due to change in the momentum of the head, characterized by a transient neurologic dysfunction that includes loss of consciousness, temporary respiratory arrest, and loss of reflexes. The neurologic recovery is complete, but amnesia for the event persists. Concussion usually doesn't produce parenchymal damage. Parenchymal injuries, contusion, bruise in the brain caused by blunt trauma occurs when brain contacts rough skull surfaces. Frontal and temporal lobes are the most common locations. Cope and countercope contusions. Symptoms include drowsiness, confusion, agitation, hemiparesis, unequal pupil size, laceration caused by penetration of an object and tearing of tissue. Diffuse axonal injury. Injury to axons at nodes of Ranvier with impairment of exoplasmic flow is due to acceleration or deceleration even in absence of impact. Results in coma after trauma without evidence of direct parenchymal injuries. Contusion, morphologic changes may be acute, subacute, and chronic. Acute, wedge-shaped hemorrhage. Subacute, necrosis, liquefaction. Chronic, plaque joint lesions. Depressed, retracted, yellowish brown patches. Stages of change: early edema and hemorrhage. Next few hours, blood extravasation into the white matter and subarachnoid space. By 24 hours, neuronal reaction to damage and old contusions, gliosis, and hemosiderin-laden macrophages. Traumatic vascular injury results from direct trauma and disruption of the vessel wall and leads to hemorrhage. Hemorrhage may occur in epidural, subdural, subarachnoid, and intraparenchymal compartments. In this slide, you can see skull fracture, frontal portion, and also you see epidural hematoma when arterial bleeding. Dura pushed away from the skull, and also in the right side you see subdural hematoma, and this venous blood play main role. And also you can see intracerebral hematoma. Epidural hematoma associated with skull fractures doesn't cross suture lines due to tearing of dural arteries, mostly the middle meningeal artery. Extravasation of blood separates the dura from the inner surface of the skull. Blood accumulates slowly, lucid interval, talk and Day syndrome may expand rapidly and becomes a neurosurgical emergency requiring prompt drainage. You see in this slide epidural hematoma. And next one, subdural hematoma. Due to rupture of bridging veins, may cross suture lines. Predisposing conditions: abnormal hemostasis, elderly with brain atrophy due to stretching of veins, and infants because of their thin-walled veins. In this slide you can find out what is epidural hematoma and subdural hematoma. Subdural hematoma. Clinical features: hematomas manifest within 48 hours of injury, most commonly over the lateral aspects of cerebral hemispheres. Slowly progressive neurological deterioration, headache, and confusion are the most common features, but drowsiness, focal neurological deficits, and sometimes dementia may also occur. Subdural hematoma morphology can be acute, freshly clotted blood along the brain surface. The underlying brain is flattened. Venous bleeding is self-limited and lead to breakdown and organization. Can be lysis of the clot, about 1 week. Growth of fibroblasts from the dural surface take 2 weeks. Early development of hyalinized connective tissue from 1 to 3 months. Retraction of the lesion as granulation tissue matures until there is only a thin layer of connective tissue. Subdural membranes. You see subdural hematoma. That compress the brain. you see types of hematoma and localization, and we can divide what's the type of them. For example, if take location, you know that the epidural space between this localized between the skull and the outer industrial layer of the dura mater, and between subdural between the dura and the arachnoid, and involute vessel in epidural are temporoparietal locus, most likely middle meningeal artery, frontal locus, anterior ethmoidal artery, and occipital locus, transverse or sigmoid sinuses, and vertex locus, superior sagittal sinus. And in the subdural space, only bridging veins play a main role. Symptoms depend on severity, and in epidural, lucid interval followed by unconsciousness, and subdural, gradually increasing headache and confusion. And computer tomography appearance, biconvex lens in epidural, and subdural crescent shaped. Subarachnoid hemorrhage is often a manifestation of cerebrovascular disease. Most common cause is rupture of saccular aneurysm or Berry aneurysms. May also result from extension of traumatic hematoma, vascular malformation, hematologic disturbances, and tumors. Blood accumulates in ventricles, sulci, and cisterns, chiasmatic cistern via a cerebral artery, anterior cerebral artery. Clinical features include sudden headache, neutral rigidity, neurological deficits on one side, and stupor. You see in this slide subarachnoid hemorrhage, computer tomography findings. The hyperdense signal in the subarachnoid space is due to the presence of blood. And next one, this is a normal dense signal of cerebrospinal fluid in the subarachnoid space. Also subarachnoid. Intracerebral hemorrhage. Intracerebral hemorrhage is often a manifestation of cerebrovascular disease. Occurs most commonly in middle to late adult life, peak at 60 years. Hypertension is the most common cause. Other causes include cerebral amyloid angiopathy, coagulation disorders, neoplasms, vasculitis, aneurysms, and vascular malformations. In this slide, you see intraparenchymal hemorrhage. Also, intraparenchymal hemorrhage of right hemispheres, and severity of traumatic brain injury can be mild, moderate, and severe. These you will have this subject neurology next years. Very important. Sequelae of brain trauma. Broad neurologic syndromes may manifest months of years after trauma. They are post-traumatic hydrocephalus, post-traumatic dementia, punch-drunk syndrome, post-traumatic epilepsy, risk of infections, and psychiatric disorders. And next topic is central nervous system infections. They are bacterial infections, fungal infections, parasitic infections, viral infections, and meningitis, encephalitis, congenital CNS infections, infections with AIDS, and prion infection. And I hope that you don't forget about prion infection, prion disease, and this prion infection. This is prion infection. First one, bacterial infections. A, bacterial meningitis. B, tuberculous meningitis. C, empyema. D, brain abscess, and limb disease. Causes of bacterial meningitis. Neonates. Group B, Streptococcus, Escherichia coli, and Listeria. Children, Haemophilus, Escherichia coli, and Neisseria meningitidis. Adults, pneumonia and meningitis. Neisseria meningitis. Pathologic types. A, leptomeningitis, most common, arachnoid and pia involved. And B, pachymeningitis, that include dura and outer layer of arachnoid. It is to remind you where are they located. Predisposing factors: A, sinusitis, B, chronic pulmonary infection, tetralogy of Fallot, D, transposition of great vessels, and other cyanotic heart disease. And radiographic features with meningeal contrast, a meningeal contrast enhancement, and neonatal cranial US. Meningeal contrast enhancement, normal CT examination is initially most common finding. Convexity enhancement occurring later is a typical finding. However, lack of enhancement doesn't exclude meningitis. May see generalized brain swelling and or focal or generalized ischemia. Hydrocephalus. You see pachymeningitis in a patient with bacterial meningitis. T1 plus S shows diffuse dural enhancement. And neonatal cranial US subtle findings: abnormal parenchymal echogenicity, echogenic cell C 40%, extraaxial fluid collections, ventricular dilatation. Ventriculitis occurs in 70-90% of cases of bacterial meningitis. Normally thin ventricular wall thickens. Wall becomes hyperechoic. Debris in craniospinal fluid. And complications: A, subdural effusion, common in infants and children. B, empyema. C, parenchymal extension, abscess and cerebritis. D, ventriculitis. And E, hydrocephalus, communicating more than non-communicating. And V, venous infarction secondary to venous thrombosis. Subdural lymphedema with strength in a patient with bacterial meningitis shows a bilateral subdural effusion with cortical surface enhancement, that is lymphedema. Note that the attenuation of the effusion is higher than that of the cerebrospinal fluid. You see here bilateral subdural lymphedema in a patient with bacterial meningitis. CT shows the important diagnostic features of meningitis, prominent enhancement of the margin and increased attenuation of the lymphedema. Abscess formation in a patient with bacterial meningitis. CT shows an abscess formation in the right frontal lobe and a right parasagittal subdural lymphedema. B. Tuberculous meningitis, one incidence and radiographic features. Incidence, the most common central nervous system manifestation of TB followed by intraparenchymal tuberculoma, seen in all age groups, although has a peak incidence in childhood, particularly below 4 years of age. In high prevalence areas, in low prevalence areas, it is more frequently encountered in adolescents and adults. Spread is usually hematogenous from pulmonary TB, basilar meningeal involvement by chronic granulomatous process leads to cranial nerve palsies. Radiographic features are basilar meningitis and abscesses or tuberculoma. Basilar meningitis indistinguishable from fungal, lymphoma and sarcoid. Intense contrast enhancement of basilar menings using CT and MRI, T2 hyperintense meninges. Later complications may be visible, including A. hydrocephalus, B. infarct due to arteritis, especially in children, and 4. calcifications occur late in disease. CT in a patient with tuberculous meningitis demonstrating marked enhancement in the basal cistern and meninges with dilatation of the ventricles. Abscesses or tuberculoma, rare unless immunocompromised or from endemic areas, usually solitary, non-specific enhancing mass-like lesions, not always possible to differentiate tuberculoma from a pyogenic abscess, tends to have central hyperintensity on T2 in contrast to a pyogenic abscess which is hyperintense, shows restricted diffusion, cerebral hemispheres and basal ganglia, miliary form, multiple teeny intraparenchymal lesions. T2 of a biopsy proven right parietal tuberculoma. Note the low signal intensity, rim of the lesion, and the surrounding hyperintense vasogenic edema. In a child, T1 and plus C, with a tuberculous abscess in the left parietal region, note the enhancing the cheek-walled abscess. Lymphedema. Incidence in lymphedema is an affected fluid collection in subdural, subdural effusion or epidural location. Epidural uncommon. Impiema is a neurosurgical emergency cause. Maybe sinusitis, most common, otitis, trauma, and postcraniotomy. Radiographic features: subdural or epidural low attenuation fluid collection with enhancement of adjacent brain. Thick curvilinear nerve enhancement of emphysema. Venous infarction lead to edema and mass effect at midline shift. Diffusion imaging is highly sensitive. Lesions are with DVI bright and with ADC dark. Concomitant signs of sinusitis, otitis. Brain and next brain abscess. Common organism, children's staphylococcus, especially after trauma, streptococcus and pneumococcus. In adults, mixed aerobic and anaerobic flora, immunosuppression, organism toxoplasmosis, cryptococcosis, candidiasis, aspergillosis, nocardiosis, mucormycosis in diabetes, TB, and atypical mycobacteria. Mechanism: A. Hematogenous dissemination, most common, intravenous drug abuse, sepsis. B. Direct extension, sinusitis, otitis, mastoiditis. Complication of bacterial meningitis, maybe as complication of bacterial meningitis, open injury, penetrating trauma, surgery, and can be idiopathic, maybe idiopathic. And abscess evolve over 4 stages: early cerebritis, late cerebritis, early abscess, and late abscess, and takes about 2 weeks to fully develop. In the early stage of infection, there is non-specific T2 prolongation in the affected region with heterogeneous enhancement. After the abscess become discrete, the classic imaging appearance is a ring enhancing lesion. The rim is hypoint. In this slide, you see brain abscess formation, a case of brain abscess caused by medication-related osteonecrosis, also gel. Radiographic features: location, hematogenous seeding, multiple lesions at GM and VM junction. Penetrating trauma or sinusitis, lesion around the entry site. Morphology: early stage of infection, thin-walled ring enhancement lesion, capsule formation, mass effect, ventriculitis, and daughter cysts. Early stage of infection. In the early stage of infection, there is non-specific T2 prolongation in the affected region with heterogeneous enhancement. Thin-walled ring enhancement lesion, the classic imaging appearance. And third, capsule formation in 70 to 40 days. Capsule is thinner on WM side because of lower perfusion to WM than to GM. Because of the thinner capsule, daughter lesions and intraventricular rupture occur of the medial side. Capsule is hypointense on T2, unlike the rim of a glioma or metastasis. An abscess rim is thin and smooth. Inner margin is often smooth. Capsule formation may be delayed by steroid administration. Mass effect, abscessed cavity, edema, ventriculitis due to ventricular spread, increased craniospinal fluid density, elevated protein concentration, ependymal contrast enhancement may cause ventricular septation and hydrocephalus. DWI bright and 6 daughter lesions. C diffusion and perfusion. High DWI signal is usually present centrally. Often this presents through restricted diffusion, low signal on ADS or ADC, and RCBV is reduced in the surrounding edema to both normal white matter and tumor edema seen in high-grade gliomas. MRS, recognition of amino acids, acetate and succinate in pyogenic abscesses, and lipid peak in tubercular abscesses. With ventriculitis, differential diagnosis with metastasis or high-grade glioma. Abscesses tend to have smoother inner wall, satellite lesions, fiber infection. Abscesses may have low intensity capsule. CBV elevated in high-grade gliomas, reduced in abscesses. Subacute infarction, hemorrhage or contusion. Differential diagnosis with subacute infarction and hemorrhage or contusion. With demyelination, with radiation necrosis. Glioblastoma, we need to differentiate with glioblastoma, metastasis, fungal infections. Causes, immunocompetent patients. In that patients, coccidioidomycosis, histoplasmosis, and blastomycosis. Immunocompromised patients, AIDS, for example, chemotherapy, steroids, and transplant recipients. In them, nocardiosis, aspergillosis, candidiasis, cryptococcosis, and mucormycosis. And we finished this lecture. Stay healthy and goodbye. See you next time.